Good morning, everybody. This is Dr. Mete Gürsoy. I'm a cardiovascular surgeon working in Istanbul, Turkey. In this session, we will talk about the angiosome concept in chronic limb ischemia. I have no conflict of interest. Tyler and Palmer described the angiosome concept in 1987, defining an angiosome as a block of tissue comprising skin, subcutaneous tissue, fascia, muscle, and bone, supplied by a specific artery and drained by a specific vein. You can see at the right side this original article. Tyler and Palmer are plastic surgeon. And then Attinger and colleagues adapted this concept to peripheral revascularization in patients with critical limb ischemia. They describe 6 angiosomes of the foot and the lower leg that are fed by the 3 tibial arteries, the anterior tibial artery, the posterior tibial artery, and the peroneal artery, as we all know. You can see at the lower side this original article of the Attinger and colleagues. 6 angiosomes have been described in the foot and ankle, which are supplied by the lower limb arteries. These angiosomes are well known. Dorsalis pedis artery from the anterior tibial artery, calcaneal branch of the posterior tibial artery, and medial plantar artery as a branch of posterior tibial artery also, and the lateral plantar artery from the posterior tibial artery, calcaneal branch of the peroneal artery, and anterior perforating branch of the peroneal artery. You can see these branches and the main arteries in this radiographic views. As I mentioned, Tyler and Palmer are plastic surgeons, and the angiosome concept was based on healthy vessels. You can see these 6 angiosomes at this side: anterior tibial artery area, dorsalis pedis area, lateral plantar area, lateral calcaneal area, and this peroneal arteries area, and the medial plantar area, medial calcaneal area. These are well-known angiosomes of the blade below the knee. Angiosome concept designed based on healthy vessels, but we are working on diseased limbs, and we aim limb salvage, decreasing amputation level or tissue loss, wound healing, increasing functional capacity and quality of life, and also life saving. Direct or indirect approach. Depending on the location of an ulcer or gangrene, there are 2 main revascularization approaches. Direct revascularization, with the other name angiosome concept, aiming to treat the vessel that directly supply blood to the ulcer-bearing angiosome. Indirect revascularization, meaning treatment to one of the tibial vessels, not feeding the affected angiosome directly. These 2 approaches are preferred in the current times of the endovascular era. In this study, El-Badawi and colleagues compared direct approach and the indirect approach. This is a current study and very well designed study. In this study, they followed 212 patients for 1 year, and they found that direct revascularization is better in wound healing, significantly better, and direct and indirect revascularization similar in amputation-free survival and the limb salvage. If feasible, opening multiple arteries endovascularly may be useful, provided at least one supplies the ischemic area directly. The classic angiosome model may not apply to patients with peripheral vascular disease, especially in diabetics. In this article, Evidence-Driven Clinical Scenario, Stimpson and colleagues emphasize these notable results. We also think like this: if feasible, opening multiple arteries may be more important in patients with critical limb ischemia. This may be named as combined approach. Revascularization of more than one tibial artery may provide better amputation-free survival. This approach can be named as combined approach, which we have also adopted. Combining angiosome-guided revascularization and indirect revascularization may improve outcomes regarding wound healing, limb salvage, and amputation-free survival. Hybrid techniques may also have an importance in complex cases. This is our treatment trial. And this combined approach, combined revascularization, was compared in this study with the direct approach and the indirect approach. Infrapopliteal angioplasty using a combined angiosomal reperfusion strategy is an excellent study of the Ambler et al. And they found amputation-free survival is better in combined approach. The pitfall of this studies is the combined revascularization approach was the only 9% of the study. So further studies are needed. And the other approach, or the one of the important approach, open as many arteries as. The number of patent arteries after revascularization was a predictor of functional limb salvage at 1, 5, and 10 years in a study performed in Czech Republic, Peregrin et al. Republic. The authors recommended making every effort to revascularize as many arteries as possible to improve clinical outcomes. In this table, you can see that the number of the patent arteries is directly related with 1 year limb salvage rate. If you open 3 arteries, the limb salvage rate is the 83%. And if there is no patent arteries, limb salvage rate is only 56%. And this is a very important document, as we all know, is 2019 ESVS Guidelines of the Management of Chronic Limb Threatening Ischemia. In this guideline, they said as angiosome-guided revascularization may be of importance in the setting of endovascular intervention for midfoot and hindfoot lesions, but is likely to be irrelevant for ischemic rest pain and of marginal value for most forefoot lesions and minor ulcers. As you see, angiosome-guided revascularization in patients with significant wounds, Wi-Fi grade 3 and 4, partially those involving the midfoot or hindfoot, and when appropriate target artery is available, guideline recommend angiosome-guided revascularization with weak grade and C level of evidence. And another important point, complete pedal arch. This is the September and colleagues study comparing risk analysis of the impact of pedal arch studies and angiosome target revascularization in chronic limb threatening ischemia. Pedal arch was important even if angiosome targeted revascularization was achieved. Angiosome directed revascularization in presence of complete pedal arch had a lower risk of major amputation compared with angiosome directed revascularization without complete pedal arch. This is the complete pedal arch, this is incomplete pedal arch, and this is the absent pedal arch. In this study of the Troise et al., pedal arch patency and not direct angiosome revascularization predicts outcomes of endovascular intervention in diabetic patients with critical ischemia. They say thus, angiosome-guided revascularization is not a predictor of good outcomes in diabetic patients undergoing endovascular procedure. Pedal arch patency seems to be a key factor to obtain good outcomes in terms of wound healing and limb salvage. Severity of wound or type of approach. This is another important point. As I mentioned before, in the ESVS guideline of 2019, guideline recommend us new system, Wi-Fi classification system in wound treatment and critical limb ischemia treatment. So in this study, Weaver et al. Compared angiosome and the pedal patency with Wi-Fi classification, and they found that in 225 diabetic foot wounds, the Society of Vascular Surgery wound ischemia and the foot infection classification system was a stronger predictor of diabetic foot wound healing than direct angiosome perfusion or pedal patency. And nowadays, Wi-Fi classification system is most popular classification system. And take-home messages. One, direct revascularization is better than indirect revascularization, especially in wound healing. Direct revascularization and indirect revascularization may be similar in limb salvage and amputation-free survival. Angiosome concept may not be suitable in patients with diabetic foot ulcers. Combined approach and pedal patency should be kept in mind. Wi-Fi classification is stronger predictor of outcomes. Thanks for your attention.